So I'll start our recording here. Then welcome everyone to our weekly Wednesday morning UCSF Orthopedic Surgery Grand Rounds. Today we're joined by Dr. Valerae Lewis, a very special visiting professor. And for introduction, I'll turn it over to Dr. Wostrak.
Well, thank you. It's my distinct pleasure to welcome Dr. Valerae Lewis, who is a professor and chair of the Department of Orthopaedic Oncology at the University of Texas MD Anderson Cancer Center in Houston. Dr. Lewis grew up in the Bronx, New York, and then attended Yale University, where she graduated with a degree in psychobiology. She then graduated from Harvard Medical School with honors and completed her orthopedic training at the Harvard Combined Orthopedic Residency Program with our very own Dr. Sig Bervin and Dr. Richard O'Donnell. Sorry if I missed anyone else that you trained with here. She then completed her fellowship in musculoskeletal oncology at the University of Chicago. Dr. Lewis joined the University of Texas MD Anderson Cancer Center in 2000. She was named the Dr. John Murray Professor in Orthopedic Oncology in 2010. Currently, and for the past 10 years, Dr. Lewis serves as Director of the Musculoskeletal Oncology Fellowship Program at MD Anderson Cancer Center and has developed this program into one of the most sought after ACGME accredited musculoskeletal oncology fellowships. And this is really a testament. We have two of her former fellows joining us today that are practicing orthopedic oncology in the Bay Area, Dr. Lee J. Morse and Dr. Steve Thorpe. So she has a great legacy with wonderful orthopedic oncologists across the country and the world. Dr. Lewis has many firsts to her name and to her credit. She was the first African-American woman to be awarded the MD Anderson Faculty Achievement Award in Patient Care in 2012, the first woman to chair an orthopedic department at a freestanding cancer center, 2014, the first woman to chair an orthopedic department in the University of Texas System, 2014, and the first African-American woman to chair an orthopedic surgery department. Dr. Lewis is a leader in the field of orthopedic oncology and an expert in limb salvage and pelvic sarcoma surgery in both adult and pediatric patients. Dr. Lewis is also an amazing teacher and mentor and beloved by all of her fellows. And Melissa and I can attest to this. We were lucky enough to be part of her ICL faculty at last year's AAOS. And the highlight of the meeting was truly the post-ICL lunch, where we got to join all of her former fellows, and they love her. It was such a wonderful experience. So we are very excited to have you with us, Dr. Lewis, and thank you for being our 2022 Orthopedic Oncology Invited Professor. Everyone, please join me in welcoming Dr. Lewis.
Thanks so much, Rosie. That was a great introduction. I'm really excited to be here. I'm sad it's not in person, but it's really an honor. It's great to see Rich and Sig. As I told the resident, Sig has been my study partner since first year of medical school. So we were in medical school together and through residency. So like 12 years. So it's great. It's great to see Sig. And I don't remember if Rich remembers, times have changed, but when we were at the Brigham, we were the DOG group, Democratic Orthopedic group. There was only two of us at the Brigham at the time. So those are really great memories, but it's really an honor to be here. And you guys have great oncology attendings, Rich, Rosie, Melissa. They're just fabulous, and it's an honor to be invited. I'm going to share my screen now. Okay, can you see my screen?
Yes.
Okay, awesome. So today I thought I would talk about a subject that I smile because it's near and dear to my heart, and probably only to Rosie, Melissa, and Rich's heart, but it's a pelvic sarcoma and hemipelvectomy and reconstruction, or really should we reconstruct? My disclosure is we actually have a CPRIT, a Cancer Prevention and Research Institute of Texas grant on pelvic surgery and hemipelvectomy, and then I'm a member of the board this year of the Academy. So just to start off, a brief review, though I'm sure you guys know, the human pelvis is really separate bones that fuse at skeletal maturity, and they form three important functions. They protect the internal organs, they serve as a point of attachment of the muscle, and it provides weight distribution. Now, I would love if the pelvic was kind of an empty bowl, but it's really full of the most important things in your lower extremity: arteries, veins, nerves, urinary bladder, a prostate in people who are born a male, a uterus in people who are born a female, a rectum, anal canal, and a lymphatic. So you see, it's really chock full of items. Pelvic resections and sacral resections really vary widely in size and shape, depending on the extent, nature, and location of the tumor. So these are 3 MRIs of patients with pelvic sarcomas. So one is a sarcoma in the acetabulum, and we see it here, and that will take one type of resection. Here is a large convolutional sarcoma that's actually obliterating the whole pelvis coming off the superior pubic rami. And then in the upper right-hand corner is a large sarcoma that's cross midline in the sacrum, obliterating the canal and occupying the entire ilium. And then here's another osteosarcoma that's really within the ilium and acetabulum and expanding that area. So you can see, just looking at these 4 films, that every time you talk to a patient, every time you go to the OR, is going to be something different, which to the residents is what makes orthopedic oncology amazing. Every case that you're seeing in the OR really is a little bit different. So pelvic resection classification actually was back in 1978 by Enneking, and he developed a classification so orthopedic surgeons could talk to each other about resections. So a type 1 resection is resection of the ilium. Type 2 resection consists of resection of the periacetabular, and type 3 is a resection that involves the obturator. Now, it's rarely just one specific type, but a 1-2, a 2-3, a 2-3, but it allows doctors to talk to each other to say what type of hemipelvectomy they're performing. So the big question I think patients have when they realize they have a pelvic sarcoma, when they come to meet me, is can they keep their leg? There are essentially 3 components in the lower extremity that lend to a functional leg. And that's your lumbosacral plexus, your femoral neurovascular bundle, and the hip joint. The key is to assess the relationship of the lesion to these 3 structures. And if any 2 of these 3 structures are occupied by the tumor, then the functional outcome of a limb sparing surgery is dismal, and the patient should have an external hemipelvectomy or a type of hindquarter operation. So this is a 17-year-old with a chondroblastic osteosarcoma. We see it sitting here in the acetabulum, but we also see it completely filling the notch. This is where the lumbosacral would exit. And on the right is the same in T1. So you can actually see nicely. So this is the old ilium, and this is the osteosarcoma after chemotherapy that is ossified, and then the soft tissue mass in the notch. She underwent, because 2 out of the 3 of those components were compromised, an external hemipelvectomy. So here you can see the old pelvis, and then this is the osteosarcoma that's become ossified, so dead with chemotherapy. And then actually you can see the lumbosacral plexus, it's now the sciatic nerve, exiting the notch, and it's really involved by the tumor. Here she is 3 months after surgery and after recently getting her leg. This was a C leg, and she could walk up and down stairs. And her goal was to walk at her sister's wedding, which was 4 months after surgery. And she, in fact, was ambulating 4 months after surgery. This is a 52-year-old male who actually had a soft tissue sarcoma. But here it is, you can see exiting the notch right here, but it's also compromising the acetabulum. He underwent an external hemipelvectomy. With our external hemipelvectomies, we then generally reconstruct the ring with either the femur, the fibula, or the tibia, depending. And we actually initially started doing that because we thought it would decrease the kind of compensatory scoliosis that we see postoperatively. That has actually not proven to be true. However, the prosthetist finds it very helpful for prosthetic wear because instead of having all that mobile soft tissue, they now have a solid endpoint. And here he is, actually, this is right after he got his prosthesis and he's learning to walk. And then here he is on follow-up in my clinic. He walks with a cane, but he plays golf for recreation and actually still swims in his pool. So even though when I first came to Anderson, our physical therapy, our rehab physicians told our patients they would be just confined to a wheelchair, these patients actually do surprisingly well and are up and ambulatory. So the big question is, when should or when can the pelvic be reconstructed, and when should it be considered? And essentially, when one of two structural conditions exist. If there's a loss of pelvic bony continuity between the acetabulum and the sacrum, so essentially a type 1 or a modified type 1, taking some of the sacrum, or if the acetabulum is resected. One of the things that's really helped us orthopedic oncologists with the preoperative planning is advances in imaging. This is that young woman with a pelvic chondrosarcoma. We see her here completely obliterating her pelvis. And one of the things, so we can take the pelvis and then we can digitize where the tumor is, and then it can spin. So we can rotate back and forth to see where we should make our cuts. And this is kind of the area that was resected, the orange, and we can decrease and decrease the level of the resection while spinning it upside down to make sure that we miss the tumor in all dimensions. So here she is after she had a bilateral 2, 3, partial 3 on the contralateral side, negative margin. She actually did very well postoperatively and was sexually active very soon after the surgery. And that just attested that she was quite comfortable with her reconstruction or lack of reconstruction and was ambulating without a cane. One of the things actually that we tend to use more are 3D printed models. They're very helpful both intraoperatively and with patient education. And these are just 4 examples of models and tumors. This is one of my partners, Dr. Bird, who's a spine oncologist, orthopedic oncologist, and you can see the tumor nestled behind really the vessels in the lung and sitting on the spine. And this was a sacral, this was a pelvic tumor that we resected. It's very helpful for the patients to visualize exactly where the tumor is. And it actually helps with surgical planning. And at Anderson, we generally do everything in a team-like fashion. This is Justin, who's an orthopedic oncologist specializing in spine, Larry Rhines, and then this here is vascular plastics, and this is the radiologist. And together they really made the model and performed the procedure. Another reason we use these 3D models, there's custom cutting guides that has been very helpful, especially when we're using prosthetic reconstruction. This is a patient of mine with the non-sterile Oncos prosthesis, but you can see first we template where the tumor is. We template where we want to make our cuts. There are cutting guides. This is what the resected specimen looks like. And then this is what it looks or should look like once we've implanted it. And here he is postoperatively, and actually he continues to do well. So when is resection necessary? You want to decide on the type of reconstruction. Really is a decision that should be made with the physician and patient together. And this is especially true when you're deciding on whether to reconstruct at all. I am not a believer that everything needs reconstruction. So we'll kind of go through the different types of hemipelvectomies. This is a type 1 hemipelvectomy, which is resection of the ilium, either partial or complete. It really is results in a minimal loss of function. When they're complete, we construct these with a double barrel vascularized fibula, which means we take one fibula and bend it over. And we do this closely with the plastic surgeons. So here, the plastic surgeon is actually measuring the defect of the resected ilium. We can see here the lumbral sacral plexus. Then they go in and they resect the fibula. And that's the harvesting the fibula. Once again, they measure the defect. They then hand the fibula off to us and we bisect it. And then we fix it into place. And really I fix it into place with small frag intermedullary screws, and then I use a malleolus screw to actually put up the fibula as if kind of doing a mini rod. And then plastic comes back in and vascularizes the pedicle by doing the anastomosis. This is an example here of the fibula that we have bisected, and there's the pedicle, and here it is in place. It's actually very secure. You can actually see that I call it the home run screw that is at the tip of the acetabulum and goes through most of the fibula, and then it's secured to the sacrum or the remembrane of the ilium. Actually, the fixation is really secure, whether you actually can shake the pelvis or kind of lift the patient off the table with this fixation. There's an up close picture of the vascular reconstruction, and the patients really do well. So here we have a young man, and he really has a non-intalgic gait. You would not know that he was missing part of his fibula. We'll see him walking back. And one of the reasons I like to use vascularized double barrel fibula is with time, these fibulas really hypertrophy. And if they're placed close enough together, they'll turn in actually to one strut. And as you see here, patients really return to activities. So he runs, he plays volleyball, he plays basketball, and he's really enjoyed his reconstruction. And you wouldn't know that he didn't have part of his pelvis. The next is the type 2 internal hemipelvectomies, and those are hemipelvectomies that include resection of the acetabulum. I really think they present the greatest challenge to the orthopedic oncologist because of the loss of the hip joint itself. There is a high incidence of failure and reoperation, and there's a significant risk of post-op morbidity. There are several reconstruction techniques. This is a allograft prosthetic composite, so where this is the allograft that's put in, and then we plate it and screw it and put in a total hip. We kind of put in enough plates and screws so that we can't see the osteosynthesis. I'm joking, but it always looks that way until it's healed. And then this is a fusion, which really I honestly haven't done in about 17 years. And we'll see why, but the patients generally walk well and stiff. And then this is a saddle prosthesis. And I don't know if you guys use them in California, but I really think it's an instrument of the devil. They say that something's not a complication if it happens 10% of the time. And with this prosthesis, nerve palsy, fracture, and dislocation all happen more than 10% of the time. So they're not complications, they're really expected outcomes. So I don't think many people use that as much. One of the things we do use is a allograft prosthesis reconstruction. So here's our resected ilium. We can see our lumbosacral plexus coming down. Then this is the resected specimen. I actually always take it with the hip to really leave the hip joint as close as possible should the tumor go into the acetabulum. We fashion the allograft to fit the defect. And I feel like this is the rate limiting step because you truly are doing cut and trying to get it to fit into place. I do think that cutting guides has been particularly helpful in this setting, and this is it cemented into place. So we plate it to the native pelvis, and then we put in a total hip. They initially do well, and this is the gentleman 2 years after surgery. Here he is walking, and he really has a pretty good gait. You wouldn't know he had a hemipelvectomy from that gait. He's an avid skier. Everyone from Texas goes to Colorado. And one of the great things is he actually lives in Dallas, and he does angel flight, and he flies patients up to Anderson. And so he is now, I don't know, 17 years out, and at this point continues to do well, though we'll see a little bit more of his story in a minute. And then type 3 internal hemipelvectomy is resection of the obturator area. And really, I generally do not reconstruct these. It's not weight bearing. And the patients generally do well. This is a 48-year-old with a chondrosarcoma of coming off the pubic rami, and you see resection here. At most, sometimes I'll put on a fibula allograft, not autograft, to prevent any subluxation of the hip. And sometimes I'll burr it out so that it's contiguous. But these patients generally do very well with minimal reconstruction. Now, this is the case that we were talking about earlier that we generally do together as a team. Actually, we do every pelvis case as a team, but my faculty and I will do this together, where Dr. Bird will come in and do the posterior approach, and then the next day I'll come in and do the anterior approach. So it's a combined iliosacral resection, front and back. And, I feel like we don't waste anything. So from the resected limb, here's the femur that we used as a vascularized femur that we put into the bottom of the spine and then attached to the remaining of the pubic symphysis. And then here's the fibula, also vascularized, that we laid next to the spine to add autograft to the spine. And here is the fillet leg flap. You can see our hands holding the flap that's on the fibula. And this is the patient's own remaining bone. So tibia, femur, fibula. This is the other side of the pelvis. And here it is sitting up in the bottom of her spine and attached to her ischium. Here's the fillet leg flap that was harvested. And then this is her own flap sitting here. She actually does well. You can imagine prosthetic wear is difficult when the resection is that high, but she does use it to go to church and when she goes out with friends and playing bridge and that type of thing. So it does give her a good option. she uses crutches. Now, this is one area where technology enabled has been very helpful because it gives you a little bit more precise or precision surgery. So patient-centric value-driven care, right? So this is actually in the OR, and this is our CT room where the patient is imaged preoperatively or right before we cut and then registered. And then we actually use these tools to really make complex, and I say kind of, three-dimensional or kind of pyramidal osteotomies where they're actually in more than one plane while sparing obviously the tumor and actually sparing the nerve roots. And it's been actually very helpful for complex osteotomies in the spine and sacrum. And one of the things that we're working on is kind of the utility of it in the pelvis. So this is just another example where we have the fibula sitting here, and then we have the femur sitting there in our patient. And it's been very helpful along with the flap. So back in 2011, I started the pelvic sarcoma team, and it was really a multidisciplinary team, consisted of orthopedic oncology, anesthesia, neurosurgery, surg-onc, plastic, urology, vasculites, gyn-onc, and then psychiatry, PT, and prosthetists. And it was really, I felt like this team was important because these are huge cases that are very difficult. But if you assemble a team, then everybody's kind of acclimated to the situation. You don't have new people who have come in and either don't understand the plan or don't understand the process. And actually, there's an article that was just accepted to JBJS reviews that talks about the multidisciplinary pelvic sarcoma team. And I encourage everyone to read it. So there are 72 phases or 3 phases to our program. It's a preoperative phase that consists of patient education. We have a video, a handbook, so the patient can actually look and see where their tumor is. They can see the different type of reconstruction possibilities, and then they can see how they walk after each of those possibilities. I always tell patients, the resection is the same. We are always going for negative margins. We're never going to cheat the margin, but your reconstruction is really when you have the different type of choices. Really important is that the patient liaison. So we have patients who will talk to other patients. They'll visit with them, less so during COVID, but really, pre-COVID, they would come in the hospital after surgery, and it helped patients set their expectations, right? I think is unbelievably important, especially when it comes to pelvic surgery, because even though I kind of tongue in cheek said earlier that you could say, yay, you're alive, and yada, yada, yada. At 10 years, they all have forgotten that they had a huge pelvic tumor, and they're wondering why they're not running and jumping. So it's really important to help the patients set those expectations. All our patients who have any type of amputation get a site consult, because one, an amputation is difficult to, I think, for patients to come to terms with, but two, especially in the pelvis, there are a lot of body image issues that they don't want to talk about with me. They don't want to talk about with their family, and the site consult gives them that option. It's preoperative and postoperative. What I say is that they don't want to talk to the patient postoperatively, don't want to talk to the doctor postoperatively, they can send the doctor away, but I think it's good for them to have that link. And then we do a preoperative prosthetic consultation, because everyone needs some type of prosthesis or orthosis because we put them in a brace. So phase 2, we have an intraoperative. So we actually have a dedicated anesthesia team that does these cases with us. On the left are the anesthesia attendings, and then we actually have a full CRNA group as well. And then on the right is our surgical team. So these are the orthopedic oncologists. Justin, Dr. Bird does spine. These are our plastic surgeons, urologists. These are surgical oncologists, vascular, and GYN. Because if you think of those original pictures I showed, the tumor is, well, one, you always need stents. I say you really need stents so that when you cut the ureter, you see the stent sitting there, but also so you can full it because the ureters feel like and look like scar. So you always know what it is. So you need neurology. But you can see sometimes the tumors are so large that they're either stuck on the bladder or encroaching on the bladder. And that's the same with the bowel. And one of the reasons I think why these pelvic tumors have a higher recurrence is that we don't go wide, right? We kind of peel it off the bladder. So that's going to be a positive margin. So we have this team there to kind of confront any situation. And the plastic surgeons have actually been fabulous with getting these patients up. And, patients come all around the world to do a hemipelvectomy, and nothing's worse when the surgery case went well and then they have a wound breakdown. So our plastic surgeons really are microvascular and they're phenomenal. The phase 3 is physical therapy. And one of the things that's different about my department is actually we have 3 physical therapists who are in the Department of Orthopedics. That's great because they're responsible to us. So that means they're responsive to our needs. I kind of joke and say our hemipelvectomy outcomes are better than anyone else's because we're better surgeons. I'll be honest, that's probably not the case. And it's really because our physical therapists work so closely with our patients and do so well. And it's often the case where patients will get surgery outside and then come to see us for our physical therapy. Alex and Colby do a phenomenal job. And we really try early mobilization whenever we can, depending on the flap. Weight bearing status depends on what type of surgery was done. And we generally use braces in the majority of these pelvises. And then the patient support network once again comes into play. This is actually a prosthetist, and he isn't at MD Anderson, but his office is like 3 blocks away, and we work very closely with him. He's phenomenal because he will spend time with these patients preoperatively, also setting their expectations, both for prosthetic wear, but also orthotic wear. And he's really integrally part of the group. It's been very productive, both clinically, because our clinical outcomes have improved, especially ICU stay and blood loss, but also from a research standpoint. I laugh because I don't know if Steve's still on the call, but the effect of the the tranexamic acid on the outcome of patients with hemipelvectomy is something that we actually started when he was a fellow. And we're just continuing to garner the numbers, gait and prosthetic assessment, postoperative scoliosis and hemipelvectomy. So it's been very productive from both the clinical and research side point. So it's a multidisciplinary approach to pelvic surgery. It's really led to greater innovation, scholarship. It has improved our orthopedic outcome as well as our hospital stays. And I really think it's improved the functional outcome. So then we started thinking, yes, our functional outcome is improved, but what else can we contribute? And the big question is, who do we need to reconstruct and why? And if we don't reconstruct them, is their function really as dismal as we were initially led to believe? So here's an example of an alloprosthetic composite. And I think they all do well initially when they heal, but I think everyone fails. And whether it's an alloprosthetic composite or a custom prosthesis, the failure rate's 100% because theoretically you're curing these patients, but there's no prosthesis and no reconstruction that can last their lifetime. And actually, this is Mr. Simmelman, who we saw was walking and flying the plane, and he called me at home, and it's as if someone had put a bomb in his pelvis. And this was like 12 years out. So he did great for 12 years, and then we had to reconstruct him and put in a proximal femur, and then do something to the pelvis. And he once again is skiing and flying, but that was a long haul. So we looked at patients with reconstruction versus no reconstruction. So patients with reconstruction, there's an increased operative time, thus an increased blood loss, increase in complications, both during surgery and due to the prosthesis. Failure is frequent. I would say failure is 100%, give it enough time, and reoperation is common. Without reconstruction, it's a shorter operating time. There's decreased incidence of infection. There's no further operation is needed. If the patient doesn't recur, there's nothing else to fail, no allograft to fail or fracture or loosen, and really infection is markedly decreased. So, but what about the functional outcome? And I will give this to say that I reconstruct a lot too. And I think it's important as orthopedic oncologists that you're facile with each option, but you also can present the pros and cons to each patient. So this is an 18-year-old boy with a high-grade osteosarcoma. It's kind of sitting in his pelvis there. It's blastic with areas of lytic. It's a skeletally mature pelvis. Here it is on MRI, a lateral and a coronal. And so he underwent resection, and this is immediate post-op without any type of metal fixation. And I say metal because we do use, I used to Merceline tape, which I hate, but now we use fiber wire. And honestly, fiber wire is the only suture that you really can't break with your hands. It's so much stronger than number 5 Ethibond. So we will attach the remaining femur either to the ischium or to the ilium, whatever we have left. So there is a soft tissue reconstruction. And then plastics will come in and put in a mesh and then close it with a flap. And here he is 7 years later. And here he is in 2017. And if you look at him, I swear his gait's better than my gait. And here he is going up and down the stairs. And he actually goes up down the stairs pretty well. I mean, he holds on to the banister a little bit, but it's foot over foot and it's quite fluid. This is another gentleman that was fixed to the ilium. So you actually see the drill holes through which we put in the fiber wire. And so he kind of developed a pseudoarthrosis 4 years later. And here's his gait, which is actually pretty good. The best thing about him is he plays the mandolin, which I think is totally cool. But he's gone back to work full time. He's a pharmacist. And really, if you look at him, you see he's kind of swinging through his spine and a shoe lift. But if you had a common glance, you would not know that he was missing the majority of his pelvis. And this is one of my favorite patients who's jogging. And this is her x-ray after internal hemipelvectomy. She like broke her wrist because she was cleaning her gutters on her roof. And she waitressed full times, holding things with both hands. So really, these patients can be very mobile without support at any age, as you see. This is what we put them in post-operatively. You know, Frank Sim, the god of pelvic surgery, would put them in a spica cast. I really think that the spica cast is an ancient form of torture that we use today. And so we actually just use this hip spica brace. Everyone hates it initially, but nobody wants to come out of it when we finally want to take them out. So we decided to look at the functional and quality of life outcome of patients with hemipelvectomy without reconstruction. And I think the key thing was to help patients with their expectations and expected outcomes, but also to critically evaluate our outcomes. Because I think orthopedic oncologists all too often make their next surgical plan off their last surgical case. So if they did a case that was a disaster, it's really hard to repeat that plan next time. But this way, we could longitudinally evaluate our patients. So in this study, we had sarcomas, that type 2s and variants, but it had to be a type 2. They had to have at least 2-year follow-ups. Initially, we began with a single surgeon consecutive patients. Exclusion criteria was no prior resection if it wasn't sarcoma, if they were lost to follow-up or no data after 2 years or died intraoperatively. The outcome measures, we actually use patient-reported measures, the SF-36 and the test scored. We use the MSTS as well, but then I want to use real measures because, you know, we've been using the MSTS forever. I am a complete Mencken disciple, but it's the worst scoring system we have. If you're like crawling into the office, you get an excellent. I mean, it's unbelievable. So we wanted actually some validated measures. So we use the modified short physical performance battery, the timed up and go, the 10-meter walk, and the 4-square test. And each looked at something different, whether it was balance and coordination, gait speed, or functional mobility, or once again, balance. And we felt that this would give information. The SF-36 in Toronto really is a generic set of coherent questions that's pretty easily administered, as is the Toronto. And then we always collect MSTS on all our patients. So this is the MSPPS, which is the modified short physical performance battery, where they're looking at tandem stance, whether it's side to side or one in front of the other. And really all patients were able to do this except our 183-year-olds, and they could measure tandem stance for 10 seconds. And you realize that these patients really have a limb length discrepancy and no pelvis. So the fact that they have balance is excellent. We then did the timed up and go, where the patient is sitting, has to stand, and then has to walk as quickly as they can, 10 meters. And the patient's over 3 meters. And overall, they did great. Less than 10 seconds were the normative controls. And greater than 14 seconds, they were at risk of falling if they were using without a device. And then the 4-square, which is really my favorite, because it measures dynamic balance as the patient. So this is someone early after hemipelvectomy, you know, really tentatively and moving. And this is someone later. So you see, he really is doing well, and they continue to improve with time. And then the 10-meter walk test. So you just walk as quickly as you can, back and forth, 10 meters. And then they have normative control. And this is one of my favorite patients. He actually has leaf-remaining. And you can see he can jog, he can jump, and then he has a great timed up and go. And you really don't notice that he has a hemipelvectomy until he turns. But overall, he's doing well. So we have 33 patients at last count in this study. ended up with 24 because of people excluded, and they were all type of resection that involved type 2. The majority of the patients are ambulating without support. Our 84-year-old is actually using a walker, but I think she's using a walker because she has terrible varus knees due to her knee arthritis. And then the majority of our patients wear a shoe lift. And I should say all our patients actually need a shoe lift, but many of our patients, especially the younger ones, don't like to wear a shoe lift because it decreases your ability to wear cool shoes or cute shoes. Good to excellent, which of course was the MSTS. And then the test was 60%. But this is the interesting data. So this is normative control. And these are all our patients. And you see all our patients without device really approach it normative control. So without reconstruction, our patients are walking just as well as the normative control patients in each of these measures, whether it's the stand up and go, or the 10-meter walk, or the one that measures balance and agility. And this is the thing when we first started doing this study that surprised us. People continue to get better the longer time they were from post-surgery. When we started, I actually thought everyone would plateau at 2 years, right? But no, as the longer they are out from surgery, really the better they are as measured by the time up and go, and also as measured by the gait speed. And it's interesting that you see everyone has a little bump, like everyone has a bump coming, and that's as they're decreasing their use of assisted devices, but everybody has that upward trend, except that one person, but everybody has that upward trend. And this shows you, so this is him in 2006, up the stairs, holding on, still really well, but this was him, oops, shit. This is him in 2015, where he's really running up and down the stairs by himself. He continues to do well. He waiters full time. He's in a reggae band. And we just got a video of him rock climbing. So he really continues to do everything that he wants to do. So the one factor that I think bothered quite a few people, especially young people, and then we felt was a cause for somewhat concern was the leg length discrepancy and then the compensatory scoliosis. So whether they used a lift or not, they had somewhat of a limp or had toe walking and then developed a bit of a back pain. And so one of the things that we started doing was seeing if we could lengthen the limb. So we used a non-invasive limb lengthener so that the patients could have symmetric limb lengths. So here it is, we put it in the osteotomy, and then over time, they increase the length of the rod and they get equal limb lengths. This is Ava. You see her, she always had equal shoulders, but that's because she has a terrible scoliosis. But what she loves is that she has equal shoes. And as any teenager is, she's a complete shoe maven. And she literally would come to each visit, I'm not joking, with like 10 pairs of shoes. Each shoe was no less than $500. And then she would have to get a shoe lift in each one of these shoes. And one of the things that she likes the best is she can now buy any pair of shoes. And it sounds trite, but it's really important to people when they have body image problems to have one less issue, and to have one less issue and to buy normal shoes. It makes a large difference to these patients. And actually her gait is improved. Here she is walking. You can see her compensatory scoliosis. And then here she is with equal limb lengths. And if you don't look at her scoliosis, she actually has equal limbs and a great gait. She actually goes to the University of Chicago, so she will take her cane for walking long distances, but she's really happy with her outcome. And this is the little boy with Lee Fermani. You can see his large shoe lift here. And then here he is now, and he actually has no shoe lift, and he has a great gait. And he's ambulating without an issue. He actually has Lee Fermani, and we had to go in and actually take that nerve loop, and he developed a foot drop, and that's why he's wearing an AFO. But now he has equal limb length, so that's great. So the next step is we wanted to determine which values were associated with improved functional outcomes. So we looked at all the factors in hemipelvectomies: pedicle flap, mesh, prolonged operating time, EBL, length of ICU stay, osteotomy location, how we suspended the femoral neck, BMI, chemoradiation mesh, We really don't use radiation in these people too much. And we looked at these factors and we tried to decide what factors actually had a determinant on outcome. Once again, we looked at patients from 2006 to 2020, 43 patients with 255 assessments. So this is where we brought in all our, functional outcome and our physical therapy assessments. And what we really found, and I'm just going to slip to conclusion because time is getting slow, is that independent amputation was not affected by age. So old people could walk just as well as young people. However, over time, the timed up and go and TIG actually declined with increasing age. And that's kind of normal because I feel like my gait has declined with increasing age. But what we really found that was particularly interesting was that the use of prosthetic mesh was associated with significantly improved timed up and go and 10-meter walk test, which was counterintuitive and actually split our data nicely because initially the plastic surgeons would always use a pedicled flap. And then more recently, they generally use mesh. And we found that the patients who use mesh actually had a better immediate and long-term functional outcome. And this is kind of no mesh. And we can see, and it's a scatter plot and it's statistics and it's a little confusing, but really the difference in plot shows a significantly faster ambulation with those who use mesh versus those who had some kind of flap, and a significantly less time to complete the timed up and go for those people with mesh. So it is fortunate because the majority of the time that we use mesh, but it is interesting because one of the criticisms from these two articles we just submitted was that flap during mesh. So it was great to have this data to kind of pour into it, but it also decreases the time and it decreases the morbidity of your patient population when they can use mesh instead of a flap. You can never have a hemipelvectomy talk without complications. I'd like to say there are none, but honestly, wound dehiscence and infection, as you would be surprised, are clearly the top two. And I put a star next to the wound dehiscence because the type of flap the type of incision we use is kind of a big saber with a T, and it's at that T where we usually have a little bit of weight breakdown. Generally, the patients do not have to go to the operating room, but just have a little bit of wet to dry. We do have some lymphedema, DVT, and only one PE, and then we have death, and those patients didn't die due to their surgery. They actually died because of their tumor burden. So in summary, internal hemipelvectomy without reconstruction offers a low incidence of back pain, a potential for high function and return to participation in both basic and advanced ADLs. Patients generally return to assist-free ambulation. And the great thing is that they can return to their recreational activities. And what I say is without reconstruction, they are their own limitations. If they want to try something, I'm all in favor of them trying it. We did limit to them at first, but I think this data shows that you can rock climb. Clearly, you can fall off a ladder while cleaning gutters, but you are your own limitation. And a prosthetic mesh is actually a great option, less morbidity and better functional outcome. So we're continuing to look at these patients. Any patient that has a hemipelvectomy at Anderson gets enrolled on this prospective study. And we're now comparing reconstruction versus non-reconstruction for different types. We're including more advanced outcome measures, just as time up and go and downstairs, and also 5 times assisted stand, which not only looks at balance, but also looks at strength. And then we incorporated different kind of tools. We did a pediatric tools and a promise tool since we have a fair amount of pediatric. We also did a collaboration with Rice University, and this is which our CPRIT is through with Dr. Fregley, who's an engineer. And we're doing gait analysis, both preoperative and postoperatively, as looking at implant design. And I do think you can make a better wheel because all the implants now just recapitulate the bony anatomy. And I think we should recapitulate and look at the forces and stress analysis, and that's how we should make our implant. So if the implant turns out to be a T, but doesn't fail, then that's a better option than putting that huge piece of metal there. So we're really looking at the forces across the hip and not necessarily the anatomy. And then I don't know if you guys can hear this, but I never think Anderson can end a talk without a little bit of propaganda.
Miles from Texas to Alaska.
I can drive a golf ball 175 yards.
I'm a sarcoma survivor.
I am an osteosarcoma survivor.
My knee is actually my foot put on backwards. My ankle was rebuilt using muscle and skin from my thigh.
My femur was reconstructed with donor bones. I had my entire left pelvis removed.
Part of my leg is made of metal.
I am a survivor.
Survivor.
Survivor. Survivor. I am a Ewing sarcoma survivor. MD Anderson kept me in the game.
Kept me.
Kept me in the game.
MD Anderson kept us in the game.
So that's the end of my talk. I want to say thank you very much. A little follow-up. The guy on the bike is actually a medical student, and I saw him around Anderson doing his rotation, and of course, totally started screaming. He knows I'm crazy, but now he actually is a pediatric resident. And the girl with the rotation plastic just won a gold medal in the Olympics for volleyball. She is a phenom, and now is my striker rep. But yeah, can you believe it? So the kids do really well. And this is a picture of my department. I really feel like, you know, you're the sum of the whole, and I have a fabulous group of faculty and APPs and physical therapists. So I'm really proud of them. Thank you so much. And I'll open up to any questions.
Great. Thank you, Dr. Lewis. That was fantastic and wonderful talk. And then those videos of the functional outcomes are just amazing to see. So thank you again for joining us. And, you know, we're all sorry that it's just through Zoom and not in person, but really appreciate it. And I think we do have some time for questions, comments. Feel free, unmute yourself or raise a hand. And I see Dr. Westrak's real hand up. So we'll start there.
Thank you so much. That was an amazing talk, and thank you for a great case conference this morning. My question is the compensatory scoliosis that you mentioned with your type 3-4, you know, internal and external hemipelvectomies. What are you doing? Have you been doing something that's preventing that? Do you ever do spinal pelvic fixation, kind of going into the other side of the pelvis to prevent scoliosis?
So Ava, the young girl who I showed, if we had done her now, we would totally put in spinal pelvic fixation, and that would definitely help her compensatory scoliosis. With just the routine external hemipelvectomies, it's not a bad scoliosis, but there's both a rotatory and a scoliotic component to it. And so we've worked with our prosthetists for the external that they actually have something that they sit on. Because what they do is they sit on their non-tumor side, but then they want to make their shoulders straight. And that's what gives them the scoliosis. So with that little prosthesis, and it's literally something they can just put in their pants. It allows them to sit on that side. So it keeps their spine and their shoulders straight. So that's help with the external. For the internals, you know, I think if I could equal out their labeling sooner, they wouldn't have as much scoliosis, but I won't do the leg length lengthening until 5 years because I'm worried. I don't want to lengthen them and have their femur to go up higher in their pelvis. So I have to give them a sufficient amount of time really to scar in. And so and I must admit it's completely random, but I kind of picked 5 years because you're kind of, except for chondrosarcoma, out of the woods a little bit at 5 with recurrence, but then you have enough scar. The kids I've lengthened, they do much better when they're young, though we will lengthen old people than when they're old. I feel like when they're older, they take a little bit longer to heal the lengthening, but kids like heal like gangbusters. So I'm in 2 weeks putting a little girl in who's getting her 3rd rod, because you only can lengthen, you know, depending the side of her femur. So she'll get her 3rd, so she has equal lengths. Overall, they did well. I hope that answers your question. But the idea of having the reconstructing the ring will stop the scoliosis was not true. So, but it's better for prosthesis. But yeah.
See, Dr. Vale.
Dr. Lewis, Tad Vale here. So nice to see you.
Good to see you, Dr. Vale.
I was very inspired by all you showed us, and well presented, and even to a hip and knee surgeon, I learned a lot from you there. One thing that struck me, and it was refreshing actually, because in hip and knee surgery and spine, to some extent, we perseverate on X-rays, and it seems like that the imaging, the follow-up X-rays are of secondary importance to the functional outcome, which makes sense. But I'm wondering, particularly in the unreconstructed, do you sometimes look at the X-ray and think, wow, there's a correlation, there is no correlation with how they're doing?
So I'm smiling because I thought the X-rays look awesome. So I think it's where you set your standards. But yeah, so I don't, and I'm laughing because Sig was a resident with me, and Jesse would always say, you don't treat X-rays. So if you have negative margins and the patient is functionally doing everything they want to do, then that's really a great outcome. So I do perseverate on X-rays less. I think I also perseverate on X-rays less with age as well.
Yeah, makes sense.
Yeah.
Let's see. I think, let's go to Dr. Bervin.
Yeah, Val, again, congratulations. I'm so pleased, and you've done a terrific work and a great career to date with a lot left to come. The debate between allograft and prosthetics, I couldn't agree with you more that designing prosthetics more according to force lines than according to anatomy. But where is that now between putting in a mega prosthesis made out of titanium? You told about your experience with some early cases, but versus allograft, where is your preference versus vascularized autograft?
So, I mean, it depends on what the resection is, on what one is an option. I think the orthopedic oncology in general has moved more to custom bulk prostheses because we do a good job of kind of looking at the tumor, designing our cuts. Cutting guides has been particularly helpful in that, so that we can get a great bony prosthesis interface. Like the case that Melissa showed earlier, it looked beautiful. We couldn't do that without really good cutting guides because the interface would not be good, for lack of a better word, and you wouldn't get bone ingrowth. So I think as a society, we've kind of moved away from osteoarticular allografts, especially in the pelvis, and more towards prosthetic repair. As I said, I think you should be facile in both. And we do a lot of, custom prostheses. But I actually think it's really important for the patient to decide and to be able to see the different outcomes, because they do have a different timeline too, right? So even though that case of Melissa looks great, she will be back there again. I mean, I always say, unless I win lotto, I won't be back there, but somebody, her junior partner, will be back there again, because they all have a finite lifetime. And I think in kids or young adults, to have the freedom of still have a good gait and living fulfilling life, knowing they'll never have surgery again, actually has been very attractive. So I think a big factor in our patients, getting them to choose, is so they can see how they walk long-term with the different options. And especially kind of teenagers, young adults, they really don't want to have surgery again, and they're really done with being cancer patients. So to know that they don't have to do it at all, I think has been a big selling point. So that huge caveat is that I am working with engineers at Rice to see if we could build a better prosthesis, because we're orthopedic surgeons and we like to tinker. So that's kind of where we are on that. But it looks more at stresses and forces and not at anatomy.
Your cases are inspirational, and congratulations again.
Oh, thank you, Sig.
Let's see, any other comments or questions from the audience? Let's see, Dr. Wostrak.
Well, since no one else is jumping, I'm going to ask a technical question. You showed a picture of one of the, I think, external hemipelvectomies where you used the femur and a vascularized fibula. So the femur was going from the residual sacrum to the symphysis. Is that correct? And where was the fibula?
I showed two. One, the femur was going from L5.
Yeah.
So there was sacrum on the other side, but not on the other side. So we put the femur and the sacrum on that side in the bottom of L5, and then it went down to the symphysis. And the fibula just laid on the spine in the area of fixation. Instead of using bone graft, we had a live fibula.
Got it. Okay.
And then in the other case, the fibula was kind of coming down on the side, not necessarily giving structural, but more graft. So if we use two things, one is just as bone graft and the other is for structural.
Got it. Okay. Thanks.
And we really do have great microvascular surgeons. And I think the team is a huge thing. So these patients used to, go to the ICU, at least for 3 or 4 days. And now with the anesthesia team and the rapid transfuser, they're in and out in 24 hours. Really, they're just in because the length of the surgery and the amount of fluid they got, but they're generally out, no more than 48 hours. And that's really because of an anesthesia team who is used to operating together. So if I say I'm losing blood, that means it's audible. You need to open the transfusion. That's not like, oh, we'll follow. It means open the rapid transfuser, put in the 5 units of blood. And I don't know, Steve knows that. Like, that means we need to resuscitate the patient. And I think it takes a seasoned anesthesia team to know that, because most people are like, oh, they'll get it. No, they're not. You're not going to catch up unless you start. So the dedicated anesthesia team has been phenomenal. So I think plastics and anesthesia, as far as the group that improved our kind of immediate postoperative outcomes, those have been the 2 really valuable people. Teams.
That's so great. And I also really like how you get psych involved. I hadn't really appreciated that, and that makes so much sense.
Yeah, I feel like I should just have psych in my clinic at all times, which I find worrisome because they say their patients reflect the doctors. And as I get older, my patients need more psych. So is that a reflection of me? But in this patient population, on a serious note, I think psych is really important, because I think body image is huge. Whether they keep their leg or not, their body does not look like what it did before. And I think that's a struggle for both young and older, not old, but for both young and older people. So I think that's particularly helpful. And also conversation with other patients is really big as well. And this is the same with rotation plasty. I think Lee J and I were talking. You have patients with rotation plasty, you're going to get more patients with rotation plasty because someone will say how great it is, and it's easier to convince things. But it's the same with hemipelvectomies. It will calm their anxiety. And pre-COVID, they would come in and visit each other. In PT, they would compete against each other to see who was progressing quickly. So the patient liaison and support system, I think, is particularly valuable.
That's cool. Thank you so much. This has just been such a treat. I took so many notes, and I'm going to re-watch the video. It was just excellent. Thank you very much.
No, it was great. It was great seeing everybody. No, it was really good.
Hey, Val, let me ask one more question if anybody has another question. But what's so impressive about what you're presenting is the interdisciplinary care. So not only surgeons working with surgeons, but the perioperative care, it really involves everything from psychiatry to physical therapy to orthotists. And what are some of the challenges, and what has MD Anderson as an institution done to try and really make it work at MD Anderson? Because there's so many other places where that just doesn't get reimbursed. It doesn't happen. And one of the things that makes you've acknowledged that makes your program great is that interdisciplinary team.
So I honestly think it comes down to is that we're salaried. So I can have a plastic surgeon wait around 10 hours to work 15 minutes and it affects her or his paycheck, not at all, right? So I think that's one of the things that makes MD Anderson extremely collaborative, because in the end, I'm going to get paid whatever I'm going to get paid. And so I can spend time on other people's cases. So they really don't get credit for these huge pelvic cases, but it doesn't affect their bottom line. So I think that's definitely the case with the surgeons. I think having physical therapy in my department is a huge factor, because I think it's human nature that you do a better job when you're hand in hand with the person who's responsible for your job. So that's been great. And they're really dedicated. And then we just lucked out with the prosthetist. So we've been working with him literally for 20 years. So I do think it's kind of what makes Anderson special is the fact that it's so collaborative.
You're Harvard's resident Democrat. I'm a resident socialist, and I think that's so. I'm so glad you shared that. So thank you, Val.
And
well,
so with that,
who was going to say that? Okay.
Oh, I was just going to say, I think we're just past time, and I feel like we could keep going, but want to respect your time too. And Dr. Lewis, thank you again so much. Like everything from case conference to presentation was just wonderful teaching. And I know that we all benefit greatly from it. So we really appreciate you joining us. Hopefully can have you in person at some point. And thanks again for doing this for us.
Awesome. Thank you so much. Hope to see you guys at the Academy.
Thank you. Thank
Thanks,
you.
Val. Congratulations again. Good job.
Thanks. I see you, Sig.
Bye-bye.